So the word biofeedback, the bio in it is basically the various bodily activities or the function, and feedback is basically we give the real time information so that we can adjust those functions. That's what is basically the simple meaning of the biofeedback. So biofeedback is basically a instrument based learning process. Here we record the various bodily activities of the patient like the pelvic floor contraction, and then we provide visual, auditory, or the verbal feedback. And these feedback, uh, basically, it will be helpful to give the behavioral reinforcement, and this help in the improvement of that particular bodily function. So biofeedback basically work on the principle of operant conditioning, or we can say on the trial and error basis. So biofeedback in the field of gastroenterology was first introduced actually for the fecal incontinence during 1974, and then later it was started for the dyssynergic defecation in the 1987. So the indication for the biofeedback, the first and the foremost which we have gathered here to listen is the dyssynergic defecation. I think this has time, this is going ahead even if I'm not pressing anything. Okay. So dyssynergic defecation, after that the fecal incontinence. Here the indication for the biofeedback for the fecal incontinence, we need to be having the intact muscle to train the patient of the fecal incontinence, and the aim of biofeedback therapy for fecal incontinence will be to improve the strength of the pelvic floor and to hyposensitize, little bit hyposensitizing the rectal wall will be the aim. Then the post-surgical rehabilitation, after the sphincteroplasty to help in the gaining of the strength. Then low anterior rectal syndrome. This here the patient will come with urgentinence, diarrhea. So we can help them actually by retraining their rectal wall, but rectum has to be preserved there. And then also we can help them by strengthening pelvic floor. Then the levator ani syndrome. Here we can work on the pelvic floor relaxation. Then the pelvic organ prolapse. Here already if the patients are diagnosed and they have underlying dyssynergia, then we can give them a sandwich biofeedback therapy like pre-operative and the post-operative. The outcome of the patient with this will be much better. Then the pediatric pelvic floor disorders, same like dyssynergia and fecal incontinence. Sexual dysfunction like vaginismus. Then the urinary incontinence and stress urinary incontinence and urge urinary incontinence. Though I'm not much working on these last three indications, I'm mainly working with the constipation and pelvic floor related, means colon related indications I'm working more. As it is important to know the indication, it is definitely important to know in whom it is not recommended. So severe neurological disorder, as sir has said, if there are neurological disorders, the nerve muscle coordination is not perfect, then it will be difficult to go for the biofeedback. Then the severe anal sphincter damage, if there is, there has to be intact anal sphincter for the proper biofeedback or successful biofeedback. Then age less than 8 years. Here we can actually titrate. If the kid is smart enough to understand what you are talking and what you are showing them on the screen, then we can go ahead. Like one 7-year girl. Even if I'm not studying. Oh, nothing is working. Happened. Age less than 8 years. So this is like we need to titrate. If the kid is able to understand what we are telling them and what he's seeing on the screen, we can take the patient around that age. Because we work with a 7-year kid she had a mild rectocele with underlying dyssynergic defecation. She really did well with biofeedback therapy. Then the uncontrolled psychiatric disorders, learning disabilities, visual impairment, dementia. If these are patients are having some of these conditions, then it will be really difficult on our part to make them understand and motivate them. So it's better to avoid the patient having these issues. Then now we'll see what is the dyssynergic defecation. It is basically a one cause of the chronic functional primary constipation. Here there is it's a acquired behavioral, sorry. It's an acquired behavioral disorder with an impaired ability to coordinate between the abdominal, anal and the pelvic floor muscle, and it like affects 40% of the patient with chronic constipation. Okay, so videographically, if we have to see what exactly how will look as a dyssynergic defecation. So in case of normal defecation, the rectal is pushing and anal is relaxing and this defecation happens. But when there is dyssynergia, so there will be either issue at the contraction at the anal wall, there will be the paradoxical contraction, or there will be either the ineffective or inadequate push effort. Either of these two things will be there in case of dyssynergic defecation. We will first see which patient, how they will come, which complaints they will come. They will definitely come with the functional constipation symptoms. So we have to see the Rome 4 criteria for the functional constipation. So here must includes 2 or more of the following symptoms. That too during defecation they should have it more than 25% of the time. Straining during the defecation, they should have lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal blockage or obstruction. Then they will be using various digital methods or manual for evacuation. Fewer than 3 bowel movements per week. These are the main symptoms where we can concentrate, or we can take this patient for the further evaluation for the dyssynergic defecation. So the dyssynergic defecation, once we have seen those symptoms, we need to confirm that those patients for the dyssynergic defecation with the help of manometry. So Dr. Rao has really given very nice the 4 types of dyssynergic defecation. So here basically in type 1 dyssynergia, what happens, if you could try to visualize that diagram which we have seen in the video, the rectal pressure is adequate, but the anal down, the rectal pressure is adequate, but the anal wall is contracting is the type 1, where the rectal pressure is inadequate, but there is paradoxical anal contraction is type 2. When there is inadequate rectal pressure, the adequate rectal pressure and incomplete relaxation of the anal wall, that is a type 3. And for the type 4, inadequate rectal pressure and incomplete relaxation of the anal wall is what is type 4 dyssynergia. So the devices which we can use for the biofeedback therapy will be the manometry, anorectal manometry, and the EMG based devices. So anorectal manometry is what I usually use. It gives various the real-time pressure changes into the rectum and the anal canal. And apart from that, it also gives the sensory changes in the rectum wall, which we can further use for the biofeedback therapy. And the second important device is the EMG based device. Here it mainly works through the striated muscle. Striated muscle is what the EMG work on. This is actually more rampantly used as it is cheap and easily available. The another device which is coming into the market by the LSR company, they are trying to incorporate EMG based devices with the that software of the manometry. So I haven't used, looking forward for that. So biofeedback therapy for the constipation, we go through a certain protocol which again is given by Dr. Satish Rao. So here the three phases they have divided. The phase one is for the evaluation and enrollment. Here we can say this is the phase of talking. Like we need to be rightly going through the proper history taking, then deciding about the evaluation and everything. Then the second step is the active phase of the biofeedback therapy, where we focus on doing and then the reinforcement. So first phase of the biofeedback therapy, which I have shown like evaluation, here we will first go through all the symptoms, and I think the 10 commandments of constipation which sir has covered, that is what basically the starting point of this phase, evaluation and enrollment. We should know the like this is actually for pain, but that's what we can use for symptom analysis for the dyssynergic defecation also, so that we can know our progress in the biofeedback therapy. Then maintaining the stool diary. This is the place exactly where that 10 commandment will come, like how is the stool, how is the frequency, what time he's going, how much time he's taking, everything, how is the consistency of the stool. He should maintain at the start and have to be like maintaining throughout the procedure also. So after like going these two important things, we have to take them for the test for the diagnosis. We will go for the manometry, we'll go for colonic transit study, MRI difficogram, all this study we'll do. And once like we have diagnosis, now like the correction, little bit correction while talking phase will come. The thorough history of laxative is also needed, so that we can tailor and little bit go on deciding which laxative to keep, how to taper it with a biofeedback therapy. Straight away, we cannot stop the laxatives. We have to go on tapering the laxatives with the biofeedback therapy as the patient goes on progressing with the symptom improvement. Then correct sitting posture. Like the sir, even in MR difficogram, we have seen little bit for this. The correct sitting posture really matters a lot, because it gives the proper rectoanal angle, and a proper push effort will be put with the help of the correct sitting posture. So nowadays, like Western toilet is everywhere, at every place. Even the villages have started getting the Western toilet. But the disadvantage of it is that what is it causing? The help of that rectoanal angle, which was in there for the normal defecation squatting process, is going. Why? Because in this position, the puborectalis is in contracted stage, and that's why the angle is here, the acute. And what we want, how can we correct it? By using the squatty pot, which sir has also told in his previous slides. So that what will that do? Once that stool comes below your feet, automatically a little bit hip flexion will occur, and the separation, the legs will already be nicely separately placed. So the next thing which we have to work on, the correct sitting, the back, straight, proper back. For that, the person should bend his the elbow and keep it on the knee. So automatically that angle and the puborectalis will go relaxed, and that rectoanal angle will come obtuse, or it increases, and it gives a nice direction for passing the stool. So correct talking is really important and required in the before going to the biofeedback therapy. So after correcting the posture, we have to talk about the time toilet training. So for the time toilet training, what we can do, those who are using the mobile in the toilet, we can ask them to use the same mobile, just to put alarm, keep it outside your washroom. Whenever, like 5-minute alarm and keep it outside the washroom. Once that get hit, you come out. This is like the starting phase, so that they should not strain too much in the toilet. And another thing which Saunke sir has focused is, whenever you get urge to pass, they should go. So, and go with the natural stimulations, like wake and go, eat and go. So like after eating 15 to 20 minutes, you usually get that colonic reflex, So better to go in that time and never postpone your motion. So these 2, 3 things we have to focus in the time toilet training. Then the diaphragmatic breathing. This you can take as a homework for the patient. You can give this as a homework to the patient so that we will understand that this particular patient is really motivated or not for going to the biofeedback therapy. Here we just teach them the simple diaphragmatic breathing or abdominal breathing, wherein the patient inhale deeply and slowly through the nose, distending the abdomen. We have to give the example of balloon. Because many times when we say breathe in and your abdomen should come out, patients will say like, how it will happen? But we have to make them realize this is what's supposed to be happen. Like after breathing in, the abdomen should distend and breathing out has to be slow through the first mouth. So this homework patient should be doing at home for at least a week or 2 weeks before going to the next phase of the biofeedback therapy. So this is actually the active phase of the biofeedback therapy where we will start doing the session. So here basically we take them or counsel them for 4 to 6 sessions of the biofeedback therapy. We place 1 to 2 weekly depending upon the need of the patient, and the duration of each session will be 30 to 90 minutes. Starting phase of the therapy, it will be lengthier as we go on progressing. Then the training is usually performed upright, is basically done with a solid state, but here we usually have water perfuse system, so I do it in the lateral position. Patient preparation is like, it's better if the rectum is empty, so we can advise them using enema if it is not empty 2 hours prior to the procedure, or we can even give the laxative a day before. Like this is my unit setup where the patient is lying in the left lateral position. I have adjusted in such a way that patients should nicely see the screen and I can also talk to them face to face, not like standing behind them and giving them whatever verbal feedback. So this is how I do. Then now what exactly we do in those sessions. So first 2 to 3 sessions I plan for targeting the individual defecation problem. In the dyssynergic defecation, we have seen there is either problem in the paradoxical, like there is either the paradoxical contraction or inadequate relaxation of the anal canal muscle, is the anal canal. Then the ineffective rectal propulsion, means we can say for time being abdominal part, and then impaired rectal sensation. So these 2-3 things like we will be focusing individually one by one. So how we focus for the paradoxical contraction or the inadequate anal sphincter relaxation. So here basically throughout the process we have to ask the patient to see the screen and start to recognizing that your anal muscle down there can be controlled by yourself. By telling them that let the patient squeeze and observe the screen, and make them aware that this is the muscle you can control and you just have to now control it to relax. Learn to relax. So then the anal sphincter relaxation sensation we can give them. First, we ask them to contract, ask them to learn to feel that muscle can be controlled, and then we go for the relaxation. So the relaxation basically we can do that relaxation by 2 ways. One is the passive relaxation, like sir has already mentioned, recto-anal inhibitory reflex is what we can use here. But more than this, I prefer using this, active anal, more than passive relaxation, I prefer using the active anal sphincter contraction. Means first give the patient the feeling of contraction and what follows is the relaxation. So just make patient more and more aware about the feeling of relaxation is what basically the aim of us here, and we have to continuously keep on giving them visual and the verbal biofeedback. Just see here, like this is, I'm focusing only on the anal area. So that red strip, I use both the screen. That screen also works, this screen also works. So here the patient, that red strip on the right side of you, that is the squeeze. Now the patient is squeezing, which can be seen on the biofeedback software. And then we ask the patient to relax. And the patient will start appreciating. Now, this small relaxation which you have seen, it takes really long time for certain patient. So not just patient, you also have a lot of patience when you are going for the biofeedback therapy, because appreciation of relaxation, it really take little bit more time, and that's why it's always better to cater one thing at a time. So like this is how we go for the anal relaxation. Then the inadequate rectal propulsion. Here, if the half part will be done if we correct the posture. The correct posture also gives the right abdominal push effort which will be needed. Then what we can do, we have to train them the diaphragmatic breathing actually. First I will cover that, which we have already seen. Here it helps a lot. We have to train them a nice and proper diaphragmatic breathing, where they understand like when to distend and when to like contract the abdomen. Then we have to give them indication about how to go about the pushing. So here the patient should focus on halfway inspiration. Halfway inspiration will little bit distend your abdomen, then hold the breath. After holding the breath, we have to ask the patient to push. So it's like Valsalva. If you could try to correlate, just take the halfway inspiration, hold the breath and push. This is how like we have to keep on giving them target. Like suppose in the today he is going up to 20, next time by practicing he should go to the 30 and 40. This way it's like trial and error, day by day progress. And one more thing we have to like advise to the patient, when they go for attempting the like defecation, as they are really pissed off with not passing, what they try to do, they just push it like anything, that they want everything out in that moment. So we have to train them, or we have to teach them that you have to go slowly even when you are going for the pushing, because you don't have the relaxation down and you are just pushing. So that also like we have to work on. So this is how like I do in my setup for push. So like first we have to ask the patient to take a halfway inspiration, hold the breath and then try to push. At start, this patient is having inadequate push effort. So here the patient has started taking the inspiration. Ask him to hold and give him target, or ask him to push more and more as we go on progressing in the therapy. Okay. So this is like individualized. We are not even not yet started coordinating. We are individualizing. First focusing on the anal area, then focusing on the rectal area. So then they will understand it much better. And at the end, then next 2 to 3 sessions, I focus on the recto-anal coordination, which become easy for the patient to understand. So in the recto-anal coordination, whatever they have learned in first 2 to 3 sessions, they just have to correlate it. Like the anal relaxation, they have nicely understood the feeling of anal relaxation, and they now even know how to modify their push. So basically what we have to now here give them, when they are halfway taking breathing, halfway inspiration and hold period is there, right? We are asking them to little bit like that hold. So start of hold, we can ask the patient, try to take the feeling of that anal relaxation and then push. So this way, like halfway inspiration, hold the breath is equivalent to anal relaxation and give push. So this way we try to like titrate in each session, but I usually go in the last 2 to 3 sessions. First I focus on individual need. This is how we go. Okay, so now the patient has started pushing, and same time we are asking him to be conscious about the anal relaxation also. though it is looking very easy, but it's really hard for those dyssynergic defecation patients to feel that relaxation and try to coordinate that with the push. So our it's our duty to give them confidence every time and motivate them that it is happening, it will happen. You just go on practicing. This biofeedback therapy basically takes multiple visits. It takes long duration. So it is really important that we have to continuously keep on counseling them in between sessions also. So apart from this, so these sessions, like now, first 2 to 3 sessions, last 2 to 3 sessions. So now when we can stop giving these sessions? Sorry. So if there is a consistent coordinated pattern of defecation with good anal relaxation is there, or there is improved stooling habit and normal balloon expulsion. So this is the time when we can think for stopping of the session. But I think the third part has gone. Okay. The third and the last part, which is there, that is the reinforcement. Sorry. It's still coming. So when to stop, like we have seen, if the proper consistent pattern of rectoanal coordination we have got and there is balloon expulsion, then this second phase of biofeedback therapy we can stop. But during this second phase of biofeedback therapy, I also focus on giving them the pelvic floor relaxation exercises, some of the core strengthening exercises, the diet counseling, and the very important psychiatric counseling. Some of the patients with dyssynergic defecation, not some, there might be actually more number. Research is not going on about the gut-brain axis more and more. So we have to take the help of psychiatric counseling if it is really needed, but not in the start of the therapy. As we go on and when the patients start becoming comfortable, we can advise them for the psychiatric counseling. This will definitely help us to improve the outcome of the biofeedback therapy. And then the last phase, that is the reinforcement phase. After the patient is nicely done the balloon expulsion, then we go for the reinforcement. This reinforcement we do 6 weeks after the completion of therapy, then 3 months, then 6 months and 12 months. This is just to make sure that the patient is doing it and he is consistent with the rectoanal coordination pattern. He should not come back again with the same dyssynergia. Just like we have to ask the patient, you need to be continue doing this at home. So home devices, if it really become available easily, it will be helpful like anything. The one more topic which I would like to cover is the dyssynergic defecation and hemorrhoids. Like in our OPD, many times the hemorrhoid patient, they come, and when we start taking the history, then they will almost start presenting with the constipation and dyssynergic defecation complaints. So even the research has shown that 30 to 50% of these patients with chronic hemorrhoids, they exhibit signs of dyssynergic defecation. That too, in 42% of the cases, even there is diagnosed dyssynergic defecation. And if there is improvement in the dyssynergic defecation, it even reduces the hemorrhoid symptoms in 65% of the patient after the biofeedback therapy. So like as many of you are like surgical people, you will be feeling like this, chicken and egg concept, whether the dyssynergic defecation or the hemorrhoids. So whatever, as it has bidirectional relationship, but what you can do along with the medical and the surgical management, if giving importance to the underlying root cause, that is the dyssynergic defecation, which can be catered with the biofeedback therapy, will definitely help for the proper or the good outcome of the hemorrhoids and also help for the good quality of life. So like as we all are clinician, we want evidence-based practices. So there are certain evidences for the biofeedback therapy. So the randomized control trial in refractory constipation patient with pelvic floor disorder, it has shown that 80% of the success rate up to 1 year. Then symptomatic improvement in ODS patient. Again, after some years, they have again conducted the study. It also shown the 80% of the symptom improvement. Then biofeedback is superior to the diet, laxative, or sham feedback in the dyssynergic defecation. Various randomized studies have been shown this result. Now, still, how much authentic these particular evidences are, that study was also done to get that the dyssynergic defecation, the short-term and the long-term treatment in the dyssynergic defecation, we have got level 1 or the grade 1 evidence. For the fecal incontinence, again in the short-term and the long-term treatment, there was level 2 and the grade B strength of evidence was found. Then for treatment for the levator ani and dyssynergia, the level 2 and the grade B evidence was found. And for the treatment of solitary rectal ulcer and dyssynergia, the grade 3, level 3 and the grade C evidences was found. This study was also done by Dr. Satish Rao sir. So I'll just like to take you through one case study or the case story. Here, a 45-year-old lady, she was diagnosed case of solitary rectal ulcer syndrome. We had come our clinic with a chronic constipation along with SRUS. So we did evaluation for that patient. We did colonoscopy to reconfirm the SRUS as that was really long standing. Then we did deficogram to get to know that that was showing mild rectocele, and the anal manometry. On the anal manometry, we got the type 1 dyssynergia. So along with the medical management for the SRUS, we have we have put this patient on the biofeedback therapy. These are her starting parameters. If you could see, I'm just popping out the push and the relaxation pressures. Here the push is 58. If you could compare with the normal, it is okay. So we can consider this as adequate push efforts. If you see the relaxation, it is in the minus, means there is paradoxical contraction happening. So this is a type 1 dyssynergia. So we have started putting this patient on biofeedback therapy, and after the 4th session of biofeedback therapy, there was improvement in her push pressure. Push pressure was already adequate, so that was adequate. But the improvement in the push relaxation was significant, and she even expelled the balloon within the 11 seconds. Previously, she has took almost 120 seconds, if you could see in the down part. She has took the 120 seconds for passing the balloon. But after the therapy, she passed it after 11 seconds. Even like the down images, that the last third image is of proper push, where the upside, the dark color are more pressure and the light colors are the less pressure. So upper part is the push, lower part is the relaxation. So this is post biofeedback therapy, post 4 sessions of biofeedback therapy. So the conclusion is biofeedback therapy, we can say it's a proven therapy for pelvic floor disorder, and it is safe and supported by various evidences. Then biofeedback therapy, we have to individualize this. We cannot fix that this is 1, 2, 3, 4 for you. No, it is not. It is like 4 for someone, it is 5 for someone, it is 1 for someone. So we have to tailor depending upon the individual need of the patient, and importance of patient selection, like it is really require a well-motivated patient to go through the biofeedback therapy. Thank you.
Thank you, Dr.